Welcome to Academy of Ultrasound's echocardiography. This is class 232, week 2, part 2, dealing with constrictive pericarditis. I'm John Sheldon. I'll be holding the class this evening, and we're going to go ahead and jump right in. We're going to start where we left off in part 1, and that is on constrictive pericarditis versus restrictive cardiomyopathy. Both constrictive pericarditis and restrictive cardiomyopathy present as a chronic indolent disease with evidence of volume overload. Commonly, the differential diagnosis is between an idiopathic restrictive cardiomyopathy and acute constrictive pericarditis. Important to rely on multiple parameters from the comprehensive Doppler echo exam to establish the diagnosis. The differentiating features marked biatrial enlargement in a restrictive cardiomyopathy, but relatively normal chamber sizes in constriction pericarditis. In both instances, an elevated EA ratio may be noted with a shortened deceleration time. That is your classic restrictive mitral inflow. High E, small a, shortened deceleration time. Respiratory variation of the E-wave velocity is increased in constriction, normal in restrictive cardiomyopathy. So you'll have mitral inflow respiratory variation with constrictive pericarditis, but not with restrictive cardiomyopathy. Left ventricular volumic relaxation time also shows greater respiratory variation in constriction. Hepatic vein and SVC, or superior vena cava flow blood patterns, also have distinguishing features but are probably less reliable and are substantially more difficult to analyze accurately than are the valve inflow patterns. Typically, systolic antegrade flow is experienced with inspiration in the hepatic veins. In restriction, there is less respiratory variation, and diastolic flow typically exceeds systolic flow. Doppler tissue imaging of the mitral annulus has been used to differentiate constrictive pericarditis from restrictive cardiomyopathy. In constriction, more rapid early relaxation compared with restriction when diastolic velocities are diminished to below normal. So look over 939. We're over here on the left-hand side at figure 939. This is a tissue Doppler of the mitral annulus. This happens to be the lateral wall in a patient with constrictive pericarditis. The EA velocities and the E prime velocity of 28 centimeters per second, which may be a distinguishing feature when attempting to differentiate constrictive from restrictive. You have more rapid early relaxation in constrictive. So you have a very, very high E prime, which is the mitral tissue Doppler indication. The final method is the velocity of propagation of mitral inflow determined from mitral color Doppler M-mode imaging, which is 940. We put a M-mode cursor through the mitral valve. We've turned on the color, so you're getting color M-mode. And you're looking for a very steep velocity of propagation, this VP that they're measuring. This has not been used in any of the labs that I'm familiar with. I'm just making you aware of it. You won't see this on your exam. Mitral color flow M mode being used in this fashion. It's in the Feigenbaum book. Should you ever run into it, you know where to go look for it and how to find it. The velocity with which the mitral flow moves towards the apex is normal or frequently exaggerated in constriction, pathologically reduced in restriction. Table 9-3 outlines the expected echo and Doppler findings in constriction and restriction. So let's jump down to 9.3 and go through these real quickly. Your atrial size in constriction is normal, restriction dilated. Biatrial enlargement is in restriction. Pericardial appearance is thick and bright in constriction, normal in restriction. Septal motion, abnormal in constriction, normal in restriction. Septal position varies with respiration in constriction, normal in restriction. Mitral E to A is increased in both. Deceleration time is short in both. Annular E motion is normal in constriction, reduced in restriction. Pulmonary hypertension is rare in constriction, but frequent with restriction. Left ventricular size, normal in both. Mitral tricuspid regurg is infrequent in constriction and frequent both in restriction, typically TR greater than MR. Isovolumic relaxation time varies with respiration in constriction and is stable with respiration in restriction. Respiratory variation of the mitral E, mitral inflow, is exaggerated with constriction but normal with restriction. Color M mode mitral valve velocity is increased with constriction and reduced with restriction. No single finding will be 100% accurate, and that a clinical diagnosis of either entity should be based on a combination of clinical and echo findings. So moving on, miscellaneous pericardial disorders and observations. Effusions are not uncommon after cardiac surgery. Typically, you'll have a patient after cardiac surgery and they'll want you to do subsequent echoes every few days to try to see if the effusion is going away or if it's growing. Postoperative effusions are most commonly localized to the posterior and lateral aspects of the heart and may be loculated. Let's go look at figure 941. See the effusion out here? Effusion down here in the bottom. Let's go look at 942. Pericardial effusion localized down here by the right atrium. Emphasis on a postoperative pericardial effusion is by definition hemorrhagic, and will be components of the interpericardial hematoma present as well. Hematoma will have a density similar to that of the myocardium and other mediastinal structures. Hematoma is a blood pocket. It is important to evaluate the size and geometry of all four cardiac chambers and identify the inflow from the pulmonary veins and superior vena cava and inferior vena cava. Loculated effusions and hematomas after cardiac surgery can result in isolated compression of one or more pulmonary veins or a vena cava inflow, which will compromise overall cardiac output. Small underfilled chambers that appear compressed may be indirect evidence of a compressive pericardial hematoma in this setting. Echo-guided pericardiocentesis. First role is in determining the presence and distribution of a pericardial effusion and the presence of hemodynamic compromise. Multiple echo imaging windows should be used to determine the distribution of the fluid. The distribution in depth from the surface of the chest should be determined Let's go look at 943. This is a subcostal picture in a patient with a moderate pericardial effusion. It's approximately 1.5 centimeters distance between the pericardium and the right ventricular free wall. This arrow is 1.5 centimeters, implying a significant distance between the pericardium and the heart, which may confer a decreased risk of pericardiocentesis if approached from the subcostal position. So they can go in here with a needle. You'll see the needle come straight down through the tissue, tap into the fluid without puncturing the heart, and withdraw the fluid. Many laboratories perform continuous echoguidance of pericardiocentesis and attempt to visualize the pericardiocentesis needle as it enters the pericardial cavity. The needle is seen as the bright, echo-dense arrow lateral to the free wall. Right here is the needle where the arrow is pointing, and they're going to withdraw the fluid. After pericardiocentesis, two-dimensional echo can be used to determine the completeness of fluid removal. There's a process called congenital abscess of the pericardium. It can occur in either a partial or less commonly complete form. Often asymptomatic. In the partial form, the left atrial appendage or the right atrial appendage become herniated to the pericardial defect and become strangulated, resulting in symptoms. Because of the lack of pericardial constraint on cardiac chamber size, there may be abnormal position of the cardiac silhouette on a chest X-ray and degrees of right atrial and right ventricular dilation. Abnormal and paradoxical ventricular septal motion has been reported. Pericardial cysts are benign developmental abnormalities that most commonly occur near the costophrenic angle. Appear as a loculated echo-free space adjacent to the cardiac border, most commonly near the right atrium. Let's go to 946 and take a look at that. You have the normal geometry of all four cardiac chambers and an echo-free space immediately behind the right atrium. Color flow Doppler would confirm that there was no organized flow within the space and no evidence of hemodynamic compromise. This was determined to be a benign pericardial cyst, right down here where it's marked cyst underneath the right atrium in the full chamber view. They distort the normal size or shape of the atrium. Additional echo evaluation must include should include contrast echo to exclude anomalous systemic veins. Color flow and pulse Doppler interrogation at low velocity settings can be used to ensure there is no phasic flow within the structure. So turn color on over top of the structure. Low velocity, turn your color gains down, and you'll see no color inside that blackened cyst. You can also put a pulse wave Doppler gate inside that cyst. Turn it on with low filter settings, and you'll find no Doppler tracings, no movement at all inside that cyst. It's a loculated area of fluid. That's it for tonight. That should finish up week 2. Dealing with pericardial constriction. As always, go to Google and you can search for these different things, pericardial cysts, these other things we've spoken about, congenital absence of the pericardium, for example. You'll find plenty of pictures, videos. The more you see, the more able you'll be to discuss this and comfortable with it. If you find any that you don't fully understand, please email them to me at john@academyofultrasound.com. I'll be happy to interpret them and try to help you interpret them. Continue your study, and I look forward to hearing from you or talking to you on the next lesson. Good night.